Thanks so much, Ricardo, and it's really a pleasure to continue or following Willem Jan and Paul's presentation because we've heard about sort of the attractive premise of value-based healthcare in that we can improve the care that we give to our patients while at the same time trying to temper the rising cost in healthcare. And it really raises the question, what about skin diseases and what about dermatology? Can that be benefit for us, for our discipline as well? I think at the moment, our specialty is lagging a little bit behind other specialties. When you take a look at the literature, there's not really much published on value-based healthcare for skin diseases. However, there are multiple initiatives present that are start looking to introduce this value-driven care for several skin diseases. And for the next 10 minutes or so, I will give you a high-level overview of some of these initiatives in dermatology with a focus on psoriasis. And I'm going to talk about three areas. The one is the outcome measurements in daily practice. The second one is how can we deliver patient-centric and holistic care. And finally, really briefly discuss payment models and how that can change in the setting of skin disease. So just really a step back and talk about why it's really important to have these outcomes that voice that give the voice to the patients. And this is a study published by Professor van der Kerkhoff, who's also on this call a couple of years ago. And I really like to show this because when you ask a physician, what is the most bothersome thing about psoriasis, you see that more than half of the physicians in blue say, well, it's the location and size of the skin lesions. But if you ask the exact same question to a patient, then you see a completely different response, and that things like itching and pain and scaling are really important for the patient. And it's really too important, I think, for a physician to take the patient's expectations and into consideration. And you can only do that by asking and including the patient's voice. So I think that's really the importance of measuring outcomes. And then, of course, is the question, so what are the outcomes that matter most to patients? And there are multiple initiatives really to help us do that in clinical practice. And one of the larger organizations is the ICHOM, the International Consortium for Health Outcomes Measurements, who's really doing a robust methodology approach to develop and implement these so-called outcome measurement sets that are condition specific and that are helpful to inform a value-based healthcare-driven care. And you can see some of the areas in which ICHOM has done the development of these outcome sets, for instance, cardiometabolic, the renal area in which William Bos also did a outcome set for chronic kidney disease. But you see that in these set that are presently available, skin disease is not one of them. Fortunately, there are indeed initiatives going on to improve outcome measurements in dermatology. There are several organizations, such as the Court-Cousin collaboration, C3, the IDIOM, the International Dermatology organization that is focused on outcome measurements, and the HOME initiative, which is focused on atopic dermatitis. And these are all international organizations that have multiple stakeholders involved, especially the patient, but also payers, researchers, etc. And they try to develop a minimum set of outcomes that can be used for a specific condition. And there have been initiatives for diseases such as psoriasis, but also for diseases such as hidradenitis suppurativa, cutaneous lymphoma, but also patient with itch. And it's good to realize that most of the efforts that have been done in dermatology and that are presently ongoing, most have a focus on research. So sets that can be used in clinical trials to harmonize the outcomes so that you can later on use them in, for instance, network meta-analysis to compare across clinical trials, but also for daily clinical practice registry with a focus on research. But the question really is, can we use these sets also to inform and improve the quality of care in daily clinical practice? And that's not a one-on-one translation. For example, this is a core outcome set for atopic dermatitis developed by the home group. And you can see that the outcome set consists of 4 of the domains. So signs, symptoms, quality of life, and long-term control. So these are the domains, and each domain has one or several measurements that you can use to measure that specific domain. So for instance, for the domain of clinical science, the preferred instrument to use is the EASI. For quality of life, it's the DOQI for patients 16 years or older. This is a set that is specifically intended for clinical trial use. And how can we then use that in clinical practice? One of the ways that we can use these sets is to do what we call treat-to-target approach, in which we have the predefined treatment goals that are often defined by these measurement instruments, and that can really help to drive decision-making in initiating, but also monitoring treatments. For instance, if you look at the DOQI, you see that after 3 months of initiation of treatment, the DOQI score should be at least 4 points decrease. And after 6 months, then the treatment goal is to have an absolute score of 5 or less. And if you don't get that treatment goal, then you can either adjust or switch from the therapy. So that's how we can use sort of these outcome measurements to drive clinical care. But this is, of course, not the sort of full cycle of improvement that Willem-Jan and Paul were talking about, how we can sort of on a meta-analysis level improve the care that we give. So I think there still need to be work done in the field of dermatology in terms of resources, both in time, but also the digital infrastructure that is needed to collect the outcomes and compare that across different centers. And I think the final point of the culture change that is really needed in terms of being vulnerable, learning lessons. I think these are things that need introduction in the field of dermatology. I would like to introduce the work of Professor Jo Lambert, who is a dermatologist in Belgium. She's based at the Ghent University Hospital, and she's really pioneering the field of value-based healthcare in dermatology, and specific also for psoriasis. And her research group has developed an outcome set, so a minimum set of outcomes, domains, and instruments that can be used to support a value-driven approach, specifically for daily clinical practice. And using robust methodology, the group of Professor Lambert has identified 21 outcomes that matter most to patients with psoriasis, and they found 12 measurement instruments to measure these 21 outcomes. And it really attests to the importance of the patient voice, because the majority of the instruments are patient-reported, 8 of them, whereas 4 are provided by providers. And Professor Jo Lambert's research group is now developing or further validating this outcome measurement in an international setting. And what the group of Professor Lambert now is doing is an innovative clinical trial in Ghent to really see if we can implement this value outcome set in daily clinical practice, and can we indeed use that as a way or as a tool to enhance and improve the value that we create for patients. So this trial is now underway, and I think the results are eagerly awaited because this, I think, will be the first supporting evidence to move towards a value-based healthcare approach for a skin disease. I would like to also take one step back in terms of the holistic care, because when we think about psoriasis, of course, we do see the skin lesions, the plaques, but that's only the sort of the external view, because of the systemic inflammation. Patients with psoriasis, as you know, suffer from comorbidities such as cardiometabolic diseases, arthritis, and also mental disorders. And if we only focus on the skin, we will not do good to the complete patient. And so I think this really attests to do this holistic multi-specialty approach for patients with psoriasis, but also for other chronic skin diseases that have this multifaceted aspect with multiple comorbidities. And I think in the literature and perhaps also in your own hospital, there are initiatives really where you have these multidisciplinary team approaches in which you, for instance, would have joint clinics with, for instance, rheumatology for connective tissue diseases like such as systemic lupus, but also psoriatic arthritis. My own hospital in Leiden, for instance, also has a multidisciplinary clinic for cutaneous lymphoma, in which we would have close collaborations with colleagues from the hematology department and the radiotherapy. And sort of these joint clinics do offer improved outcomes compared to this sort of silo-based care that we traditionally have. But these are not, I think, the complete full-based healthcare approach that Willem-Jan and Paul has shown. So I think there's more work to be done. And I think one of the possible methods that we can learn from is the integrated practice unit, in which the care is organized around the patient using multiple disciplines, rather than the patient being sort of rotated from one specialty to another. And I will not go into too much detail on this topic, because this will be the topic of the next webinar in this series, which will take place on September the 20th. So I would cordially invite you to join that and to see how we can learn from other disciplines who have this more IPU approach already implemented. So finally, this is my final topic, is the topic of the payment models, because in the formula that Willem-Jan and Paul has introduced, you have the outcomes over the costs. And I think one of the items in value-based healthcare is really re-informing or restructuring actually the financial structure to reward not volume, which is sort of the gold standard at the moment, but really moving towards more a reimbursement for value. And I came across a really interesting pilot study being done by colleagues from Denmark, who have piloted a outcome-based reimbursement model based on the patient benefit index. So these are treatment goals that the patient himself has set, and you would then get reimbursed if you can reach or if you can get those targets, yes or no. And I think an interesting part also in this model is that they also took into consideration factors that have been known to decrease the chances of treatment response. For instance, patients who are obese or who are smoking, they might have less odds to have successful treatments. So the reimbursement structure is really dependent also on these risk factors. And I think this is one of the first ways in which we can transition also in dermatology from a fee-for-service model to a fee-for-value reimbursement. So I come to my final slide, and I think it builds upon the two previous speakers, that value-based healthcare has a lot of benefits in the first place for the patients and also then for the providers, but also for multiple other stakeholders that take a role in healthcare, such as the payers and suppliers. And I think it also has benefits for the society as well. And I think that these benefits will, I think, trigger hopefully you as specialists in the dermatology field to start looking at value-based healthcare and see it as a really interesting and innovative approach to restructure the healthcare with the ultimate goal of providing better care for our patients.